All right. Good evening and good morning, different continents, and we welcome. Can you hear us and see us?
Dr.
Yes, sir.
Samin,
Good morning, sir. Dr.
nice.
Samin, Dr. Malani here.
Madhav.
Beautiful. All right. So I know that as a moderator today is Dr. Anant Raman and our expert panelists with Natrajan, Sushil Malani, Devendra Shrimal, and Pramod Kumar. And I know there are a lot of other lectures we have. With that note, we welcome all of you from Mount Sinai, myself, Dr. Kini, and we have our two fellows here, Ranveer Singh and Prithvi. We big fellowship program of 10, 11 fellows in various capacity and intervention, and trying to show some targeted plaque modification approach in this Meet the Masters. And today will be the combination of the rota cut so we are ready with the case. We start showing. Let's the first one. This is all of you here. Hopefully we have not missed it. I know there's one person. They told me that Gautam, I think, will not be there. This is the incorporation with the Boston Scientific India and ESCC Jaipur and Mount Sinai Fuster Heart. We have no disclosure. And this is episode number 23. So we are doing 6 per year for last 4 years. Next one will be in November. So this is a patient, 69-year-old, presented with the class 2 angina recently and ischemia on PET-CT. Control factors on the left side, you can see we, in addition to putting the LDL patient non-diabetic, but we still check the A1C routine in our lab. We actually soon will start doing a LP little a routine testing, and this has led to multiple papers of the CRP, LDL, which we do pre-procedure routinely. Normal creatinine, patient has a known chronic coronary syndrome for 2 decades, a few angioplasties few years ago, and on good medical therapy. Basically, the angiogram showed earlier this month with the 2 vessel calcific disease. One was taken care with a good ejection fraction, and now the second one we need to take care today. And Anu will show that angiogram now it's a non-dominant right. And plan would be the IVUS guided stage complex PCI of the calcified LAD-D1 bifurcation using rota cut plaque modification and the mini crush stenting, which will make it from appropriate point of view. We always show this slide. Region age, even we took care of the circ, there is still a LPDA totally occluded and LED diagonal here. So I'm going to show it now. Okay, we can show the angiogram.
So if you see the LV gram, EDP was 10 today. And then
LV
we had
little down.
Yeah, though we said in the past was okay. It looks maybe
mild
in
diffuse,
the 50,
maybe.
yeah, mild diffuse.
Yeah, actually LV in the past had been down. They put patient on Entresta and Aldecton. EF then last time became 55, maybe a little lower here.
So like we said, non-dominant RCA, but still occluded. And this is where, so you know, it's a short left main, essentially non-existent 2 separate ostia. So I think one of the teaching point here is when you have that kind of anatomy, FCL is a good curve to get into we took a 3-5 because last time when we did the circ, we used VODA VL, and that was, you know, selectively engaging into the circumflex. So 3-5 was not doing it, and then we went with the 4-0, and this is where we are. This is a LAD, where we have proximal LAD. If you see a short lesion, and you can see the calcium as well as before the dye comes in, but I would say significant disease. Then I would say ectatic, not aneurysmal, ectasia, less than twice the size of the vessel at just after the lesion, where you have the diagonal originating. So it could be why this case could be challenging, because once you have that kind of ectasia, wiring side branch could be a little challenging because the side branch is coming, originating at that particular area. So we may have to do just cranial to see if the ostium is involved or no. But even if the ostium is not involved, there is significant disease of this moderate size between 2.25 to 5.25 as a large size diagonal. Then mid to distal LAD, you see Cipher stents. Very old cipher stents.
And they're doing good.
Yeah.
Cipher, even with the neoatherosclerosis, probably mild disease in the mid segment, further down, but that remained fine. Was done 10, 15 years ago, and so okay.
Apical LAD, all the way where you see the LAD that's
Yeah.
wrap around. You see calcium as well as some disease. This could be of significance because if we are doing rotational atherectomy and any kind of distal embolization happens in a rare situation, you may develop slow flow. So just be mindful of that. In certain cases, we have to go all the way down and quickly open that lesion so the slow flow disappears. So all these things to be kept in mind if we are before starting rotational atherectomy.
And we are no RO caudal view is not there, right? Yeah.
We did not.
Okay. All right. That's fine. Okay. See, and questions now while we are wiring the LAD now.
That's
Do you
an
want
excellent case, both Annapurna as well as Dr. Sharma. And for Annapurna, I was in Cardiff. I was a Cardiff guy. So I was a new.
Oh,
Yeah.
was it before my time or after my time?
I just about joined and you left. So
Oh,
I was-
okay. Good
So,
pullback.
Now, with regard to the case, coming back to the case, Dr. Sharma, I think it's excellent case. It's 64 with adequate LB and the bifurcation is calcified. Now, going back to your kind of RotaCut study as well as all the other studies, this will be an excellent case to discuss in and out of all the sort of rotablation cutting balloon, why we are doing RotaCut, all those things. So I will start with the panelists and throw some questions to them and also their kind of opinions on how they will deal with this case. So it's a clear LAD diagonal bifurcation, clear calcification is there. Imaging is going to be crucial to assess the calcium morphology. Following that, in terms of the panelist, would you do a rota with cutting balloon or would you just do rota alone? Would you do a cutting balloon alone? How will you decide? If we start with Dr. Sushil sir, Sushil Melani sir, your opinion, and we'll move on to the others.
Yes, first of all, Dr. Sharma, a great case for the plaque modification of a calcified disease, bifurcation disease.
Yeah.
Now, let us see, first of all, what kind of bifurcation we are dealing with. If we go by the definition criteria, the side branch appears diseased, but not to the extent of 90%, which is the criteria for non-LM complex bifurcation. But yes, definitely a calcified disease. So that is number one, whether we want to do a provisional stenting and the leave side branch just like that and do a bailout strategy for if it gets compromised during the procedure. That is number one. Number two, it's not a lesion which that we expect that the IVUS catheter will not be crossing. So probably a pre-dilatation imaging will give us calcium score and appropriate tool to modify this lesion. Now, whether we should go upfront rota or after imaging, we decide about rota, oblique, some other plaque modification, that we can discuss, But definitely,
Beautiful.
if the calcium score is high, 2 or more on the IVUS or say 3, then probably a rota followed by another balloon strategy, whether a cutting balloon or some high pressure NC balloon, that we can discuss as the case proceeds.
Yep, and particularly just data came out, the two trials just presented last week, actually this week kind of, TCT, comparing with the IVL, one in the cutting balloon in the rota, a short cut approach, and the second one with the victory using with the open NC, and they actually both perform equally good. I mean, that was surprising.
Yeah.
In terms of, I mean, again, they were short-term results. Whether it will make a difference in the long term, we do not know. But definitely, there a lot of IVL people were concerned when they have a big showdown with the Shockwave big booth, and now two major trials did not favor any additional advantage, and except the cost is much higher. In America, same thing there. The IVL cost is still, just because of the single agent, is about $4,700. And open NC is $1,200. Cutting balloon is 700, regular balloon is 200. I think similar prices are there in India also. And those all will change by next year, because we'll have at least 3 FDA-approved devices which will come into the market. Tectona with Abbott, and we are working with our fracture Bolt with the Boston
Bolt
Scientific.
Medical,
There actually we have done 300 cases already, 200 in Europe and 100 in America. And I'm in the lead enroller here of the 100 cases. We have done 27 here at Sinai. So that device is working very good. And there are many other fast wave data were presented. So a lot of new devices, then competition will drive the cost. Okay, let's see what is happening now.
So you're already in the distal stent of the
native lesion. Yeah, eccentric calcium. This proximal vessel. Yeah, a lot of calcium. Huge size gap. And osteo LAD has some lesion.
Okay. Tell us now in terms of the calcium arc.
Sure.
We need a thickness stuff.
Let's go step by step. So let's talk about the stent first.
Yeah, so this is the previous Cypher stent 2006. It's expanded. Like not much neointimal hyperplasia. Area is like 5.5 or something.
Good.
It's open. Still previous stent.
Yeah.
There's some calcium inside the previous stent. So proximal edge of the stent is kind of tight lesion.
Circular calcium there.
Yes, this is inside the previous stent. Then now come to the native. There's some calcified nodule here.
Okay, hold on. Where is that calcific nodule?
This is just
proximal
before,
edge.
Yeah, almost proximal edge of the previous Cypher stent.
Okay, keep coming back.
Yep. Then come more proximally, eccentric calcium again. So yeah, now huge size gap. And the big branch here. Before that, yeah, here is our tightest lesion. Yeah, so our tightest lesion is like almost 270 calcium, very tight. Like MLD is like 1.6. Yeah, then the big branch. Yeah.
And how does the ostium of the diagonal looks by this LED picture?
So this is a pullback from the main branch, but looks like this is the level of the side branch. From this view, looks open. The ostium of the dia.
Ostium is open. Okay. Yeah. So just coming back to the point that whether we do a single stent approach or so, remember there is a still significant lesion in the diagonal. May not be at the ostium, little further down. So in that case, maybe we can avoid the mini crush and just, ostium looks good. We can always confirm by the IVUS selectively. And if it is, we can avoid any, we all know, once you have 2-stent approach versus 1 stent, because there was no disease, that still will be better.
Okay, so go back to the tightest area. Don't open yet.
Yep. So this is the tightest, like 270 calcium tightest lesion.
That's where it is. And then you are barely reaching 1.7.
Yeah. Which is
MLD is like 1.5.
Good.
Okay, 1.5. Yeah.
So we are just getting ready.
I know a lot of discussion already happened, but we do have the published algorithm of how to manage this calcific lesion. If you can show that. You want me to talk now, later?
That we can talk a little later, right?
Okay.
Yeah. Right now I can just show, go to the slide. So I just want to knowing that this cutting balloon is coming into the player and maybe it will become more. If you can show the slides, go back there. Because there are 4 papers. COPS was the first one, 100 cases, non-compliant versus cutting balloon. And particularly at the area of the high calcium, the cutting balloon gave a bigger lumen, MSA, compared to the high pressure balloon dilatation. Except there was a perforation in about 2 cases, means 4.4% perforation did happen. That's the only other points were all identical. But just to say, cutting balloon does help over non-compliant balloon. Then the second group was prepare calcium combo. It was a rota cut lesion with Orsiro, and then they used the control arm of the prepare calcium, modified as well as rotational atherectomy arm, and did show that combining the prepare rota stent, cutting balloon, rota stent gave a better lumen as you can see, in the rota cut approach, bigger lumen, although the other complications were not different. Stent expansion was also better. The third one, which we did, our target vessel failure was still remained the same at 9 months. The last one was the rota cut trial, which we did. Rotational atherectomy, 60 patients, cutting balloon versus rota and high pressure balloon, and we did not find any difference. There were no complications. This was a short-term trial of acute outcomes of 30 days. There were no complications in the trial of 60 patients. We didn't have any CK release, no MBs, and no perforation. But approach of the rota and cutting balloon and rota NC balloon has identical 6.5 and 6.9 MSA. With those. So there are some plus minus. Then there is another one, cutting balloon versus conventional balloon, prediction near IVUS. They are actually showed all of a sudden in these cases that cutting balloon gave a bigger lumen. So there are plus minus data that cutting balloon, particularly in the calcific arc, does give us a better lumen compared to just non-compliant balloon. Whether it will translate into a lower TLR, that is has shown that way. But cutting balloon also, they all have shown that go to 16 to 18 atmosphere with the Wolverine now. But don't go to 22 atmosphere. They did in the COPS trial. COPS trial, they had a perforation of 4%. So don't go 22 atmosphere, but 16 to 18% is a reasonable, because we went 16 atmosphere in the rota cut trial, and in 60 patients we have 0 perforation. All right, Anu. Ready?
Yeah, so we have the rota in the proximal LAD just before where we want to start. We already did the 3 steps, okay? So here you have your knob, move backward, forward, remove all the tension between the Teflon sheet and the burr. Any tension between, then Y connector is open, any tension between the burr and the wire. And now on the dyna, you just do a tap. You see that the burr did not move. So we are off dyna and then we are ready to burr. So it's a 175 burr, slow pecking motion. And I think this is what we want to keep teaching, that we are going to do slow pecking motion, not the fast speed. Every time, few millimeters, see that? A little bit. You have to be loud when you hit 20. So when it's 20 seconds, the tech has to like raise his voice and tell me, stop.
Yeah, so we actually, I'm thinking about putting the noise. Remember in orbital atherectomy, we had 25 second. It's a 25 second, not 20 second. 25 second, it is a beeps, boom. And there is no, in the rota is not there. So I'm working on, because this Rota Pro, I designed with working with the engineers of the Boston Scientific. So maybe we should add that at 20 second, it just makes the noise.
Yeah, that's one. And even the laser has that.
Yeah.
The safety feature. Yeah.
Yeah. Annapurna, if I just ask you, I think you are too quick because I saw you, the workouts were the micro catheter and then changing to the rota wire, and that's probably the safest in terms of practice for the novice who are joining this. Now, in terms of the burr sizing for this vessel, 1.75, the logic behind that, and what is the advantage of 1.75 over 1.5 for this particular case?
Okay, can I just finish this and take the rota wire and then I will, I will write,
Yeah.
So you see that again, slow pecking motion, because there's some teaching that goes where they want to do fast. Okay, I think this is looking good.
Yeah.
So we're done, and this is a nice final. And then we are coming out. So back on dyna, and you have to do brake release, and and the fellow is going to. So I'm going to come out. He's just advancing. Our fellows, they are just like 4 months into their fellowship. They are completely confident in doing rotational atherectomy. Prithvi, who is my fellow here, he's for 2 years, he's doing some great research work, but more important, when he's done from here, he's going to go back to India, taking the flag of Mount Sinai and have his his own research center and will be doing most procedures the way we have taught him here.
And rest of the staff in this room, I'm sure those who have been watching, they are all familiar with the CVT being Asif and Hakim, our nurses Will and Aldina, and imaging is Kiski. Yeah.
Like we have protocols for most of the procedures we do, even our nurses and technicians, they go through a lot of training and protocol. Like when we are doing procedure here, you see that they know what to do. They take care of the patients in the site. So we are just focusing on this side of the bed. Head end, they're taking care of the patient.
If the blood pressure is down, we know that rotablation less than 100, they'll give neosynephrine, that bolus of 0.1 milligram, 100 microgram, sometimes a little more, needed to increase the pressure.
So going back to the question we had, right? Why we did, can we do, now when it is a short lesion, you can always say severe calcified short lesion, you can think that we can use rotawire. But you have to remember this rotawire is a wire that was probably designed 30 years ago. There has been no improvement in this wire design. It's a stainless steel, there is no core. The current wires, the way they are made, there is a core, and then after that, there is other, the way the wire is made, the tip has some other material which can be hydrophobic most of the time, but majority of them are now having hydrophilic coating, which the one-to-one torque that you are trying to torque here at the leg or in your radial artery, but the torque is there at the tip and it usually listens or behaves. That's what we say. We tell the fellow in the initial part, the wire doesn't listen to you, but at the end, as you become familiar and get more used to doing procedure, the tip has to be listening to you. But this stainless steel wire has no core, so it's not that easy to manipulate this rota wire, but having done so many years of procedure, yes, we can do direct rota wire. But would not do that in this case. If you see that, it definitely does not look normal, probably a little ulcerated. So in that situation, you want to go with the regular wire, then fine cross and then exchange it. So it'll be faster also, less radiation. So if you see here, this is what we did. We took a microcatheter and this is a fielder wire. So I was having some trouble in manipulating. You see, that is how now we are able to get across that lesion, just because it was the fielder wire. If it was rota wire, many times you will have to use the clip, the rota clip, to do this kind of maneuver. It may happen, may not happen. So if you want to do faster, means quicker, this is the way to do it. So exchange it and done. That's one. Next point that was asked is, why did we select 175 bar? So most of our old publications and very earlier stage, it used to be 0.7 bar to artery ratio. Then right now we are saying as long as you're 0.4 to 0.5 bar to artery ratio, you're okay. So angiographically, even if you think it is a 3-5 vessel at that level, so it will be 0.5 will be probably 175 if you're looking angiographically. So that's done, but now we did IVUS. Kiski, go back to exactly where I asked you.
So
Tightest lesion.
Yeah,
and
this
this
is the
is
tightest
what,
lesion.
Yeah.
since we started doing a lot of
Can you show the IVUS on the screen?
imaging, so this is the tightest lesion, and you put your diameters there.
1.5.
Yeah, go back. Go back there.
MLA.
Yeah, show it.
But the vessel diameter, a lot of calcium artifacts, we cannot measure this level of the vessel size. So we should
We
go
are not
to
talking vessel size. I'm talking the lumen.
lumen is 1.5. This is
Yeah,
one.
no. Show the diameter.
Yeah.
Yes.
This is AI measurement, like a two.
Measurement, you see. So it's 1.5 to the other side is 2.2, but average if you take. So we are saying that, yeah, if you go with 1.5 bar, it will just go through the lesion. It's not going to do any kind of calcium modification. So 175 was safe. Now, going back, we have this. Another point is, it is a short lesion. Tight, short lesion, so 175 bar is safe. If the same thing we are talking about long lesion, when we are saying long lesion more than 20 millimeters and you have severe, means this kind of a, we would have then said maybe 175 bar, only because your embolization, the debris will be large, means will be more, and there's a risk of having slow flow. So that would be a consideration. So going back to the point, based on the imaging, short, significant disease, diameter at that level was 1.5, so we know 175 bar probably will do the job. And you saw that the way the rotational atherectomy was done, slow pecking motion, in the sense that you go 0.5 to 1 millimeter forward every time, and at 20 seconds you stop.
And based on the angio also, I would have gone with a 1.75. The rota wire, as you mentioned, after the long time, 3 years ago, 4 years ago, they changed the rota drive. The little bit of change in the shaft, the spring tip remains the same, but the rota, this is not a user-friendly wire. So therefore, very low resistance or threshold for us to change it to the wire, over the wire system, and easier. Because what happens is many times the spring will go, the 0.14, and because of the combination, the tip of the body of the rota is wire is 0.005 at the tip. So that causes that inertia, and then it stops there. And therefore, it's easier to just go, it takes few seconds, and you are done with it. Exchange. Now, straightforward lesion, probably you can go. So in our lab, I would say probably 20%. We go with the rota wire directly. 80% we do the exchange.
Thank
Dr.
you.
Sharma, going back to the first image, IVUS image, what score, calcium score, based on the IVUS, we keep discussing about the IVUS score, or OCT score of the calcium, and then deciding the appropriate tool. So was there a calcified nodule just at the proximal edge of the stent, or it was just a thick calcium plate? And what IVUS score you would put it to go for a rota in this case, probably?
Okay, can we show the algorithm?
Yep.
Where the slide? Put it just now?
Yeah, he knows. Put it up. The first slide.
Where is it? My aim of raising this issue is only to discuss whether rota will be really required, or can we get away without a rota, some other strategy, that's all.
Yeah, no, that is true. Yes.
Yeah. So if you see here, going back to your exact point, where is the IVUS score we are talking about? You see that? So go to the, where is it? Oh, next. Yeah, deep. So deep calcium, which with IVUS also you can see how it looks. So we have both octade and IVUS aid. Okay, what is important is understanding these images, and then how can we use it in our clinical practice. So that is why we have to keep looking at this kind of images. So when you have deep calcium, you can do whatever you want to do. OPN balloon, cutting balloon, or maybe IVL. But what we see in everyday practice is the middle, which is a superficial calcium, which is what this patient had. So we are asking, most of the time, OCT is better, but for various reasons we cannot do it. Most important is a tight lesion or some kind of creatinine issues. The first and foremost, if your imaging does not cross, you're done. And that you guys, whoever they are comfortable with some kind of atherectomy, whether it is rota, OA, just do it. And very rarely people do use laser, though recommendation is mostly RA or OA. Then the question was, what kind of IVUS, parameters that we are using. So right there, you see that the arc, which we said was 270 in this patient. Length was not 5 millimeter, barely there. Was there length?
Yeah, 5 millimeter?
Yeah, 5 millimeter length. And more important is that, or calcium score of more than 2. But another score which we did not see is that if you have 360-degree calcium, that itself gives you another score. We did not have 360, but we had 270. That is where we are. And then you see, can we use rota, OA? Yes, you can use that. If somebody says, no, I will just go dilate it a little bit and then use IVL, yes, can be done. But more important is subsequent is, next. Like here, we are just going to do high pressure balloon and see whether it's fully expanded or no. That is somebody who do not have IVUS, because we have to remember, okay, we have access to all these tools. There are many people who have no access to all these tools. Then you go with what fluoroscopy will teach you. So you have to see a full expansion on fluoroscopy. If not, on imaging, you have to see the calcium fracture. The word calcium fracture is mostly used when you're doing OCT. But we are now talking it in IVUS. It's very rare you can see it, but if you see it good, just go and do stenting. Okay, if not, that's the time you need to decide. Do I go with a larger IVL? Means if you already did IVL, do you need a bigger size bar?
Yeah.
In OA, yeah, it's easier. Maybe we always tell, if you want to do OA, go to the lower speed. But if you think we are now calcium modification did not happen, that's the time you go high speed.
Yeah.
So you are going to do an imaging run now?
Yes, we'll do it right now for you, and then we decide.
The rota wire is still there.
Pramod.
Yeah.
Dr. Pramod, comments on the case, because you have a lot of experience as well.
Yeah, hi, Dr. Samin and
Yes.
Dr. Annapurna. Thank you very much for giving us the opportunity and also demonstrating your skills and the approach to calcified lesions. One point I would like to make is with the OCT, you can measure the thickness of the calcium, and that has some bearing in choosing the devices. And I think the case is going on well. But one question I want to ask is, when there is a nodule, which strategy would you adapt? Would you go with the OA or go with the RA? That is always asked.
Okay, we have another algorithm for that.
Yeah.
You ask it, we provide it.
Okay.
Yeah.
And we have apps for you.
Okay, I start
We'll show you that.
This is after
Let me
we
just finish this.
It's coming.
And the trial. Now we are actually doing a nodule shock.
Okay, one second. I
Nodule
stop it.
shock
One
trial
second.
at present.
Okay,
It didn't
let's
start to
finish
work.
the
I
image.
check the
Yeah.
image again.
Okay.
Okay,
Show the
start to
imaging
work
now.
It's coming. Okay, looks like it's not moving.
Yeah.
Okay, hold on.
Yes. Any
It
stuck
came
here?
out. Oh, wait. 1 second.
Yeah,
Wait. Okay, now go.
Okay, start to
Are we
work.
okay there?
Yeah,
Yeah, go.
It's a previous
moving
stand.
now?
Okay, coming.
Yes, now it's moving.
Yeah, it's pullback speed 4. It's a native nodule, proximal, huge. Yeah, this is the tightest part. Left main. The oscillator is fine. I
Okay.
will stop it. Okay, I will show you the tightest
So
part.
just the tightest area
Yep.
is of concern. Let's go back, flush it.
So this is the tightest, but it's kind of rotation.
We see few cuts there.
Yeah, I mean the MLD was 1.5. Now it's 1.78. Like we did 1.75 loader, and some like reverberation. This is, I mean the surface of the calcium is smooth because it's shaved. A lot of reflection. So it's a sign of the surface is shaved by the rotor. So, but we did not do the
Cutting
balloon.
through.
So actually the fracture, not sure,
Bigger, no? 3 to 5? No?
Cutting
3 or
but definitely the surface is shaved.
Okay, we're going to use a cutting balloon everywhere. Now, let's see what you guys feel. What are we going to do with the side branch?
Yeah, and cutting balloon basically 3O is good, 306. Cutting balloon native vessel, clearly a lot of point was made during the presentations that they've all selected 0.5 lower. Cutting balloon compared to the vessel size. Vessel size is 3O, they get 2.5. Was 3.5, they went with a 3O. 3.25 and 2.75. And then go to 16, 18 atmosphere and oscillate. They actually had multiple oscillation and multiple advancement. Same. But you go in, we rotate it, so you cut into the different area. So cutting balloon techniques are evolving. The second inflation should be slower than the first one. First is okay, but second inflation should be slower. Gives the time for the balloon pleats to get away. Otherwise, they can have some perforation. I mean, not perforation, rupture of the cutting balloon. And rupture of the cutting balloon can create a trouble. But I think the cutting balloon is coming back. And now we have a few of the scoring balloon, cutting balloon with the angiosculpt and then of course the true cutting balloon.
Done.
Score flax. Used to be a chocolate balloon. I don't know whether chocolate balloon will call it a cutting balloon category or I mean scoring balloon category. But more are coming.
Okay,
More are
done.
coming in that area also.
Done.
But simple concept of the scoring balloon, the wire outside and one wire of the balloon itself and doing the cut.
Go.
And same way you can do it because you already have a wire here in this case so that you have 4 blades of the
Done.
3O and so the rota wire is adding an additional blade. That's what we do and that's helpful in
Go.
if you're using just with a non-compliant balloon. Yeah.
Dr.
Taking
Sharma,
time will
So
slow.
this is a 3 mm Wolverine cutting balloon, yeah?
Yeah, exactly. Yes.
Good.
And we are going
And
to
what pressure
16
is it now?
atmosphere.
16.
16.
16, yeah. So we do not go 22, which has been, go again, go advance again. Go.
Where?
Yeah, go back once again, yeah.
Where?
Proximal segment, yeah, not
Okay,
tightest one,
okay.
proximal, yeah.
We did.
Yeah, once again, just to,
Go
and second time go slow.
Okay.
And yeah, so with 16 atmosphere. So I think the 22, they're very important because when we have our rota cut paper published, then we have Colombo's group sent to us that if you would have done a 22 atmosphere, maybe would have results better in MSA. But we answer that is very simple. Yeah, you may be, but then you have a perforation. And we saw that maybe that area go back again. Yeah.
Where?
The
We are not
perforation,
going-
we have 0 perforation in 60 cases, and there are 2 to 3 perforation and we are 50. That far?
This one. No,
So I
that's
think
a
the
little.
one valid
Go.
point you made,
Yeah.
Go.
COPS people, they undersized the cutting balloon 0.5 and
Down.
they went to higher pressure. So they undersized and went high.
Yeah.
But yours, rota cut was good
Go.
sizing and the pressure
Yeah.
was 16. So the result
16,
was
yeah.
safer and
Yeah.
better. Yeah, absolutely.
Yeah. And they
Now
kept
seems
the
to be
same
more
one in their shortcut. I mean, what was this?
Shortcut and synergy.
Huh?
Shortcut.
Yeah.
IVL.
Yeah, no, I know. They're also, no, it's against the cutting balloon too.
Cutting balloon.
Balloon, they kept the same, 16 atmosphere. They didn't go 22.
Yeah.
So just to
Okay.
understand one point here that you have 2 wires right now because your rota wire you left in place and then use the cutting balloon over the normal workhorse wire.
That's right, yes.
Supposing if you are using a cutting balloon strategy and you have just 1 wire, go ahead with just 1 wire or
Yeah, one
does it
wire.
still-
No, that's okay. Yeah, that's one wire will be good enough. So purpose, we have 2 purposes of the leaving the other wire. One, at the balloon, it will work as a modified cutting balloon, like a score flex type, that one wire against. Second is that if the lesion does not open up and you want to upgrade the burr and you have the capacity with that. So we have a 7 French guide. 6 French can take up to 1.75. 7 French guide can take 2 burr. Or you can go to the IVL, then it's not an issue. So IVL, actually, a lot of newer generation IVL in the shockwave itself are quite exciting at present. But the key is that if you want to do a rota, you have a chance to upgrade it because the cost is different. Clearly, the rota is half cost than IVL. So that's one of the reasons which we say we leave it all the time. So now you're putting a wire into the diagonal. What are you doing?
Yeah, give me a new filter wire. This
Yeah.
is gone.
So we are just going to wire the diagonal and then decide about putting the long stent, long synergy.
No, let's see what they decide. Do we go into the diag or?
No, diag has to be taken care.
I mean, okay.
Diag, if not to the ostium, you don't need to bring a stent to the ostium. That's simple. But
Okay, then get us a 225.
yeah, we
right?
have the balloon. Yeah.
What do you have? 225?
Since you have
2 to
a
5,
IVUS on
2.5.
board, you will do the IVUS for the diagonal as well. I assume that just take a quick run of the IVUS image through the diagonal into the LED.
We have it. Yeah,
I think it
2.5.
is about 2.5 diameter.
Yeah, 2.5. We are
Ostial
2.5.
sparing lesion. Maybe
That's the key.
prevaletion and possibly a DCB.
Yeah. So very
We
good
have the
point.
other
So
expert panelists. I will
Yeah.
probably get some opinion from the other expert panelists as well. I think Dr. Devendra Shrimal is joined. So if you can have
Devendra,
some
okay.
comments about the case. After that, Dr. Karthik was here.
Yeah.
So Dr. Devendra Shrimal, are you there?
Um, Regarding the diagonal, if
Yeah.
this is a good size diagonal, but looking to the ostium, it is also not very much diseased. So we can leave, we can do like provisional stenting. At the same time,
Very
we can
good.
do imaging in this case, and later we can decide
Do the
the
imaging
structure
there.
of the diagonal.
Okay, we'll do
Karthik,
one more
I can
imaging.
see you are there.
No balloon imaging. Yeah, so question is drug-coated balloon. I can tell you what happened is drug-coated balloon is a little trouble in America. One, because of cost, 5,500, 5,500. While in India, that's a comparative is about same, $600-700 should be, but 5,500, which is called a highway robbery. But that's the way it is. Right now, it's only one available. We presented data of the solution ISR. You saw it. I have the top enroller. In their 300 patients, I enrolled 70 patients. And there came out reasonably. I mean, it's called non-inferior because 80% was the stent, which is okay. Our goal was that can you avoid the second layer of stent in those cases? The answer came out, yes. So here is the cost. And then if you do, let's say in some cases you can still use it, but then if you're not ISR,
Start feedback.
you'll not be paid.
It's diag.
Oh,
Okay, now we're in the diagonal, yeah.
Yeah, some mid lesion, eccentric calcium.
Sir,
Here
that
also
rotated
it's
disease can be used even after doing
DCB is very
angiography and
expensive in India.
LVEF.
Okay, what about the ostium?
Sure.
We know the disease further down quite.
So
Ostium
this
is
is the
good,
level of
right?
this is the level of bifurcation. This is actually the osteo D1. Yeah, lumen is open like 5.5.
Ostium is good.
Yeah, ostium is
Further
open.
down only.
Yeah.
So,
mid
so
part
ostial
like
lesion sparing
calcific.
stenting we do. Now there was some question. Somebody else, somebody commented something.
Dr. Sharma,
Karthik,
Dr. Karthik here.
Yeah.
2.5?
Yeah, and
I think it's too big.
if you look at the
2.25.
system is clear. There's no
2.25.
problem. There's a focal lesion down. Can we take care of that focal lesion with a DB and leave the ostium and just
Yeah,
do
no, we just talked about that. Yeah, so no, we just talked about it because of the reimbursement point of view.
No, long, 15.
Yeah, from the reimbursement point of view, that practice which we know is a very good
15.
practice,
Is
but
it a 15?
is not being adopted in America because of the cost point of view. Cost is 5,500 for the DCB and will not be reimbursed, and particularly if it even other cases, it is reimbursed only on Medicare patients who are discharged outpatient. Now they just changed the code as of this month. Things will get a little better, but reimbursement is lagging behind the device introduction. That's where we are.
Tell him to give
And of course, now by
2.25
next year,
synergy.
we expect by first quarter of 2026, we'll have a solution which is a sirolimus combination available. Then maybe with the competition, price will go down. But so therefore, just to coming back to
Get
the
a
point
balloon ready
that
for the
using
stent.
drug-coated balloon strategy in the diagonal, which is what I would say I will do because ostium is not involved. Let's say I'm doing a case at ESCC Jaipur, I'll use the drug-coated balloon, but here will not because of although it's a good practice at this time or changing good practice, but there's nothing against putting a stent.
Pressure.
So remember, most of the trial of the
18-20.
small vessel also like 2.5, still drug-coated balloon and it's not a true side branch. It is an independent vessel. And then if you go with the rack cage free, still they were identical. A small vessel and with a drug-coated balloon and stents were identical. It's not that was advantageous. Yes, very long lesion, I would say. The small drug-coated balloon in a small vessel, drug-coated balloon may have some advantage, but otherwise, in this kind of particular case, it's okay to just put a stent. The data will be about the same, not necessarily better. Now, the question comes is you have true bifurcation, and I know that the bifurcate trial did show the benefit of drug-coated balloon, but drug-coated balloon against non-compliant balloon, not against the stent. Remember, most of the trial of the bifurcation, when the DCB in the side branch has been tried, it has been tried against the non-compliant balloon, not against the stent. So I still believe that you have good size vessel, side branch, your stent probably will do a reasonable results, or maybe equal. If not better, they will be equal the DCB.
Sir, if we can understand from your experience, supposing if you want to leave it just after predilation as a good old POBA strategy, do a imaging, no serious dissection, no flow limiting on angiography, Would you leave it without a drug-eluting stent as well to the side branch?
No, I mean, I would say only case that would be the patient is planning to go for surgery, and we say, okay, we'll bring back after we know the restenosis rate will be much, much higher than balloon angio, than the DES. So therefore, in that case, the situation where I would leave it only will be the in cases, synergy, yeah. In the cases where you patient going for non-comply, non-cardiac surgery, or patient has a bleeding issues. So in that case, I would leave it, but otherwise, just put a DS. Yeah.
Right.
So
Okay.
what's the
Tell us
plan
what
here?
you do. Yeah.
Please.
Yeah.
No, we're going to stent the side branch.
Okay. What size you are getting now?
I started with a 20, but I have to put a 28 stent. You still cannot find it?
Are you planning for a mini crush technique here?
No,
Or,
we're leaving it that
bifurcation?
now. Yeah. So question
Remember,
was.
we said the osteum was okay.
Yeah, okay, yeah.
So
So we're
idea
just
was
going to spare the osteum and yes.
Yep. Exactly.
Just focal stenting. Okay.
Yeah.
28?
Yeah.
Yeah,
So we're going
28
to
is
do,
good. Yeah.
I mean,
Based on the initial
lesion, you
IVUS.
see the lengthwise. So it's about 24 millimeter. So we're putting a little longer stent. But there was a disease quite a bit in that diagonal branch anyway. You go to other one. And
Was it
yeah, so an
cutting
idea is that
balloon?
avoid, no, this one just was a high pressure balloon, non-compliant. So we are going to avoid the osteal involvement. That's the key. So not putting a,
Okay,
and
what
that's
you want for the main?
main,
Let's
we
finish
can
the
have a
case.
3.5, 38,
38 is too
Yeah.
long. Huh?
right?
No, I think you have to cover up to the previous stent.
Yeah,
So
yes,
38 should be
exactly.
okay.
Yeah, 38, go.
I think 32 should be
Yeah, looks
okay.
like
No,
38.
38, yeah. Okay.
The proximal edge of the cipher stent to the proximal reference in 24.
No,
So-
that's why I said 32.
But you have to cover
38.
there a little bit there.
Oh, you want to cover the
So
cipher
38.
stent also.
Oh,
Okay, good.
And what about the ostium of the LAD? Are you going to?
yes.
No. Osteum of the LAD is fine.
No, in other
Yeah,
two was
there was a
little
plaque,
size.
but area was like 5, 6.
Yeah.
MLA was rather
Good.
Okay, yeah.
Yeah,
Top.
we checked the initial pullback. It was like 5, 6.
4.81 maybe.
6.3 is the osteo LAD area. There's a nodule, calcium nodule, but area is open, osteo LAD.
And just beyond the ostium, that was 4.8 or something.
Okay, give
No,
us
it looks
stent for the
open.
main vessel. Pop again.
Yeah.
Yeah.
Fine.
Yep.
Okay, down.
Yep.
Open.
So what stent are we taking for the LAD?
We're taking a 3.5 38 Synergy XD.
Yeah.
Yeah. And then we can post dilatation probably 3.5 there.
Sure.
Get a 3.5 15 or 12 high pressure. 15 will be okay.
Are you post-dilating the sideband stent as well, or just leaving it?
No. Everything is looking good there.
Yeah, let's see. Right now it looks
That stent
okay.
expanded well.
Yeah.
For the audience who's joined, just going to highlight this IVUS is the Avigo Plus because it's got the automatic lesion assessment. AL algorithm is there, and it makes
Good.
your life much easier. So
Okay, good. Go.
compared to the ones the others were using before. So this is Avigo Plus one.
Yeah. So they're actually going to change that. About 10 machines are coming to India, or might have arrived of Avigo, and they will start changing into many centers.
Yes, slowly. Yeah.
Yeah.
This is quite helpful. The ALA algorithm, the automatic lesion
Exactly.
assessment is quite helpful. It saves a lot of
Very, very helpful. Yeah. And particularly with this AI algorithms, I mean, these are the ones they should help us when your cutting balloon, when your
Let
modification
us
is
ask
done.
Kiski.
Yeah.
Kiski,
Yeah,
tell us what is that AI algorithm?
Yeah, it reduces time a lot, but 90% of the cases it correct. But this kind of calcified lesions, sometimes AI miss. That's why anyway, we should double check with the human eye. So still it's not perfect.
It's very important
Yeah,
what Kiski
absolutely,
is
yeah.
saying, that when there is
It is
calcium
useful.
and many times, yeah, but don't depend on it completely.
No, absolutely. I think
it
it's
is definitely
useful for
faster and
distal
more accurate
reference,
What do you
proximal
do for the
reference,
distal
other
segment?
things.
Which one? Yeah, that one you can just balloon this with this.
Okay.
Post dilate, no?
Yeah. So there is a little bit distal.
It's not going now.
Let me go
Okay.
negative.
Okay, go.
Okay, good. Right?
Yeah, that was there even before. It could
Yeah.
be that there was some.
Yeah. So probably some neoatherosclerosis in that area.
No, he did say there is a calcium within the stent. That was that
Yeah.
area on the IVUS.
That's a classical neo. Remember Cypher about 18 years ago? The neoathero within there.
Okay.
Yeah, more
Good.
inhomogeneous kind of picture that was.
Yeah.
Yeah.
Good.
Okay, get the IVUS.
Okay, do the IVUS. So we are just doing the last IVUS and hopefully we'll be done with that and we start our didactic discussion.
Now this again very crucial, and what you're showing, you do the IVUS first, assess the lesion, again you do the modification, IVUS again, see whether you have modified proper, stent, again IVUS to make sure that you have got a good result in the stent. Because there's no point in doing an IVUS in the end or IVUS in the beginning, it doesn't help. It's a very nice demonstration.
You will pause the proximal LED stent only if you find
Yeah.
that there's some issue on the imaging. That's what we understand.
That is correct.
Yeah,
Yes.
yeah,
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 because remember
yes.
we had done a lot of plaque modification. We had done the rota cut, and if it expanded nicely, then we leave it. I can tell you within our group, I actually post dilate my lesion maybe less than 50% of the time, 40-50%. And there has been no issue in terms of our TLR or stent thrombosis. We are routinely, if you have long lesion like 38 millimeter stent, I would dilate. But less than that, if looks good, angiographically, we just don't do. Okay, let's go to the IVUS on the main screen, please.
Okay, start feedback. The previous Cypher stent is coming. Feedback speed 4. Looks like this is a new stent. Yeah, well expanded. Long stent, eccentric, bifurcation.
So we need a proximal edge of the stent.
Yeah.
Needs.
I see some malposition.
Okay.
3.5.
Go back there. Yeah.
Yeah.
3.5, 12 high pressure. So proximal.
Go to the
Right?
proximal edge of the stent. Yeah,
Yeah, that because the vessel is
Yeah.
4.0.
true.
Yeah.
The lumens
Yeah.
follow.
Yeah.
This is the
So
edge
you
of
want
the
a 4.0
stent.
there?
No, 3.5 high pressure will be okay.
No, hold on.
Yeah.
0.86. So what are the numbers you are looking for? Please
0.4,
tell them.
more than 0.4 is a
Yeah.
malposition, major
So
malposition.
you see that? Anything more than 0.40. So go back and show how to measure that.
Yeah,
Right
so
there.
this is the level of the
So it's
proximal edge.
0.86. Yeah.
Yeah, there's some gap.
Hmm.
But yeah, this lumen is 4.5. But the point is, if you go super aggressive, it might cause another
4.0,
dissection
4.0.
Then
because it's
4
on the calcified plaque. So
Give us a 4.
a follow is good enough.
408 or 12?
4.0.
12.
No, 8 is good.
Yeah, because
So
this
you
is
don't
that
want
area of the aneurysm. Remember that ectasia actually. This is that area of the ectasia.
Yeah. But the other part stent is well expanded, just the proximal edge malposition.
Yeah. We are going to go 8 and avoid post dilation at the level of the diag.
Your diag looks okay. Looks very good. Ostial mild, very minimal plaque shift. Rest of the diagonal looks fine.
Yeah, maybe a more carinal shift or mild plaque shift
Yeah.
causing a
Yeah.
slight pinching of the diagonal.
Yeah.
But very minuscule, very little, yeah.
So in retrospect, Dr. Sharma sir, I mean, your
Yeah.
sideband stent was about maybe 5-6 millimeter down the line after the origin of the
Yeah.
sideband from the main.
Purposefully, yeah, purposefully.
Okay, go.
Would you have converted into a proper bifurcation as planned mini crush or something, or this is the best strategy? What would you say?
No, I would say that, remember, if you have a no disease of the side branch, which is, in this case, we'll call that as we did not appreciate that much before the angiogram. in the past. But if there's no disease of the ostium, we know that if you routinely start putting, stent probably will have outcome will be slightly different. Then you just leave it alone. And that's what in this case would be. That we are not doing anything to the ostium, because anytime you have where the ostium was not involved, you leave it alone versus you put a stent. The stent definitely will have a little higher TLR. Yeah, that's for the reason, and that's why we did extra time. We did imaging to really see the ostium of the diagonal, even after the modification of the plaque in the LAD diagonal. So that's where we are now, taking the last picture, hopefully. I don't know, what do you think?
Yeah. Now we have this giving some vasodilators.
Yeah.
We are rehabilitating the vessel.
So what pressure did you go for post-dilatation with a 4-row balloon?
We went to 16, just at that proximal edge. Yeah, that's why we took a 8.
8.
Okay. Yeah, go.
Yeah, good.
Good.
So I can tell you that any time non-compliant also, once you start getting 22, 24, that's where you have a perforation.
Yeah.
So I tell everybody, it's maybe take a bigger balloon, but go to lower pressure rather than a small balloon to go to very high pressure. So this is what we did in this particular case, and all looking fantastic. Apical LAD actually opened up, maybe just by the wire. See that apical LAD opened up by maybe the wire tip.
Rotawire.
Rotawire, just whatever calcium was, little bit, or fat. The ostial LAD is mild disease, but if everybody is okay.
I want to show them that. Remember, somebody asked a question on the nodule.
Nodule, yeah. Nodule we have. Yeah, we have. I have the slides. You want me to take it? Yeah. But any other questions so far from our panelists and or any our audience?
So one question here.
Excellent
Rota drive wire, which is being promoted as a better alternative. Any experience on that? Because the cost is almost double of the rota floppy wire which we have.
Oh no, that's a again, I call it a highway robbery. It should be the same. The cost should be the same. I mean, because that's their new generation.
Correct.
The rota drive or rota floppy, it's a little more one-to-one torque, slightly better.
The nodule.
They change the body, the tip still remain the same. They change the body a little more, the torqueable, and the junction of the rota drive versus rota floppy is little more smooth. But minor changes, nothing for the cost point of view. I'm going to speak to the Boston Scientific team. They should not increase. I know the Rota Pro cost is slightly more than the Rota Legacy. That I understand a little bit. Right? But there has to be a difference in the Rota cost versus orbital atherectomy cost.
She looks at it.
Clearly, it should be lower. And more importantly, there should not be extra premium on the Rota drive, floppy and so, yeah. Okay, so
excellent demonstration, sir. Excellent demonstration of the case.
And let's say the calcific nodule which you ask, Anu is going to just show that,
Yeah, so if you see that, I think we already discussed, which is the best intravascular imaging modality. If you see that, we see it better with OCT, but this is how it will look on the IVUS. So once you do that, of course, always we tell you, if your imaging does not go, you really want to do imaging and decide. If you do not go, upfront RA and OA. Do we have the slide? Shaking versus shaving?
Yeah.
And then this is what happens. Suppose you did your imaging, and you have seen non-eruptive. Okay, we are talking about non-eruptive. Remember, there's another modality where we say eruptive, which probably will not require any kind of modification. So once you have eruptive nodule, I think Kiski could have showed it to us. Once you see it, it is not just seeing the nodule at the site. Okay, what you need to see is what is the arc of calcium. We call it a calcium plate. So if your calcium plate is more than 270, right? Then that is what we have seen, that the stent expansion is not that easy, and they also come back at that same area. So if you see your calcium nodule and your arc of more than 270, like we showed you right now, what is the MLD at that area? So if it is more than 1.5 at the calcium nodule, you definitely have to do RAOA first, okay? If it is not, means if your MLD is more than that, you see that? That is when you think you can use a larger bar RA, or if you're doing OA, go high speed. So you understand how this works. That you at the diameter, MLD is bigger, you need to share, reach the calcium plate. In that situation, a bigger bar, or somebody says, no, I only want to go with IVL, that's fine, do IVL, or high speed OA, so you're able to reach the vessel wall. Yeah. So we have seen that, the way Rota works, which is direct versus how the OA works. Then comes the if your arc is less than 270, you go with the, what is important is you can do RAOA. But if at the MLD is smaller, you go with RAOA. If not, we can go with just big bar. After that, once you have done RAOA, and if you will, what we do is, remember what I documented, you do PTCA, and once you've done PTCA on the cine, you document that the balloon is fully expanded. It is called as poor man's IVUS. You're not going to do imaging again. If you think it's fully expanded, we can just go ahead and stent it.
We have a shake or shave if you want. Yeah. Can you change this?
So the next question comes, should you use RA or OA when you have a nodule? And we have a publication on that also. The only reason we have put OA is many people think, though it is not clear, there's always this discussion, OA probably works better on the nodule, but I feel probably RA works better until you have head-to-head. We cannot. Where's the next slide? Coming?
You can go next. Yeah.
Next.
Can you show that shake or shave?
Yeah, so I think a lot of people believe that OA does a better job in the calcific nodule. Maybe, I can't say for sure, but I know that works quite well.
This is nodule shock?
No.
No.
Next. And next.
Next.
Oh, sorry. Skip. Yeah.
So this is what we published. You see that? Shaking or shaving. So when we say RA, we are shaving. You see that? Your nodule. Nodule is like this. Can you see me? Doing my, okay, your nodule is like this. So you have to shave with the RA, okay? With the, what we did otherwise, if you see that, which we showed that where we also used IVL, and we say, can you shake the whole calcium plaque or the, what we would say, the plate. But that is what, this was our first publication that we said, that OCT guided IVL for calcific nodule in mid-RCA, and I was guided RA for CN. But it's two different regions, but if you see the size of the nodule, we also we use the terminology, it has not been published, that your nodule, where we're calling it massive. When you use massive, it's more than 90 degree. It's like Himalaya Parvat. Massive nodule, not that easy. So that kind of a situation, when we see, we think you will need at least two modalities. Do RA followed by plus minus IVL depending on the arc. I hope I made it clear.
Okay.
Yeah, very well. Thank you.
Yep.
Thank you very much.
Yep. All right. So with that note, if we can just start our discussion, I'll join you in a few minutes.
Wait, 1 second.
What happened?
There's one other question they had.
Yeah.
We have slide for everything except we don't know what the questions, how they're coming. And then I wanted to show.
No, I think we have to do some cases of the OA for calcific nodule to see how much it cuts. RA versus OA. So I can tell you a lot of people believe that OA does a better job than any other technique in the calcific nodule. But we'll never test it. We are only testing IVL versus rotational atherectomy.
No, just show me quickly the basic, or the core, how the wire core is made. I don't need the whole thing. So all this, remember all this, we have created we have apps which we are going to show, the OCT, IVUS, wire. You don't have the... Okay. Stop there. Yeah. So why RotaWire is so difficult to handle compared to, this is a Gaia Next, it's totally different. It's a CTO wire, one of the best wire that has been made by Asahi, because they use what is called as a X-strand coils. You see that? Act 1 and X-strand coil. What I am trying to tell is that the core, you see that there's a core in the center. That, so the core in the center, and on top of that there are extra coils. That is how the newer technology is. And because of this kind of a wire technology, the one-to-one torque of all the current new wires are excellent. Like I told you, you're doing something at the groin level or radial level, and it's transmitted immediately because the technology is so good, and this is what is followed. The RotaWire is a 30-year-old technology of a stainless steel from where it starts to the tip is different depending on whether it is a Rota extra support or the Rota, which is a floppy, which we use. Is the tip is a little different, but other than that, everything is the same. There is no core. So you need a core for your one-to-one torqueability. That's all I wanted to show.
Okay. Thanks everyone, and see you shortly in few minutes.